Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, this is Dr. Nada. How are you? I have seen your votes on the group, guys, and you have decided that the most important module for you to revise is oncology. And I don't wonder why, actually. I know it's not your cup of tea, and I know oncology is a little bit tricky in the questions. This is not because oncology is difficult, it's because many of you are not really aware of the guidelines regarding oncology module. So I just want to stress over a very important point, which is pre-malignant lesions are very much more important in your exam than the cancer itself. So yes, they can ask about the broad management lines in cancer. They can ask about staging, of course, but they are not going to go in depth or details of management of a specific kind of cancer, because this is not you. This is not going to be dealt by you. You are going to refer her to an oncologist, but you should know at least the broad lines. What's more important, and you are going to be a part of the team managing a patient, is pre-malignant lesions like ovarian cysts, like CIN, like any kind of cervical dyskaryosis, precancerous lesion, endometrial hyperplasia, VIN, for example, the vulval conditions that can lead to vulval cancer. Today, this video, I'm going to discuss with you the most important points regarding colposcopy. So before we start talking about colposcopy, and as you can see, I'm opening the huge guideline for the standards of quality assurance in cervical screening and, of course, in colposcopy related to the Irish guidelines. It's an amazing guideline, and it contains the algorithm, the very famous one that you all know. I just wanna start with the basics. The basics are how we are going to start the journey of cervical screening. Cervical screening now is all about doing two things. The first one is, yes, excellent, HPV testing. So we are going to do HPV testing, and then if the HPV is positive, I'm going to offer this patient cytology. It's not vice versa like before. And I want you to deal in the exam just like what's going on now. I want you to deal with the question from the point the question is leading you. Simple English. If they mentioned that the patient is having high-grade dyskaryosis in cytology, shall I go back and do the HPV testing? Or shall I move on with colposcopy? No, you shall move on. Okay? So I need you to deal with the questions from the point they are putting you. Okay? Don't go back. So again, number one, HPV testing. If HPV is positive, I'm going to do the cytology. The cytology is positive for any abnormality. I'm going to refer this patient for colposcopy. Why? Because I want to see closer. The colposcopy is going to give me the chance to look closer. Sometimes the cytology is not enough. Sometimes the presence of HPV is not enough. Both of them could be not enough to have a problem or a big deal. So, am I going to offer all women with HPV positive testing and an abnormality in the cytology a treatment? Of course not. So, what is the step that's going to make me sure that this woman is having a real problem? Colposcopy. Colposcopy is like very closer look to the cervix, and we are going to use some techniques, additional techniques, to see if there is any changes with the structure of the cells of the cervix. So I want you guys to have a look here. This is how the squamocolumnar junctions looks like. This area is our main concern because this area is what's called transformation zone. And this is where any changes or pre-malignant changes could happen. So we are going to have a closer look over this area, which is called the squamocolumnar junction or the transformational zone. Actually, the transformational zone is the area between the original junction and the new junction. What is original? What's new? It's anatomically speaking, when the woman is getting older and older, the new squamocolumnar junction is going to develop. This is where she is born or how she's born here. And when we get older and older, this area is going to widen. So it's really normal to see that this transformational zone is now extending into the cervical canal. It's going to be deep until you are going to see this. You can see the out border, but the inner border needs you to have a closer look. Okay? So this is why we have the colposcopy. So we are going to have a look over this area. And we are going to write down any notes. This is, of course, the job of the colposcopist. The colposcopist is going to have a look over the structure, the appearance, the color, if there is any irregularities in the surface, if there is any change in the color of this area, if there is any bleeding, if there is any punctuation marks, if there is any new vascularities, white areas when he apply the iodine or the aceto white pigmentation. So we have two types of pigmentation, actually, the aceto white and the iodine. So both of them, he's going to apply one after one and see if there is any changes. Those changes are going to be his clue if there is any abnormality in this part. And he is having a grading system. This grading system is, according to the findings, he can grade these changes as, okay, this is not really CIN. No, this is CIN1. No, this is CIN2. Or maybe this is something like more severe than this. As you can see here, this is an example of a typical epithelium. I can see things that are abnormal, but there is something really unique here, which is I cannot see the extent of those changes. I cannot see their end. And this is something really bad. Why? Because I should see where the changes start and where they end. Here, he can see the changes. As you can see, we are having some punctuations. We are having some white areas, some ulcerations, but I cannot see the upper limit, okay, of the whole area. I can only see its upper limit here, but down below, I cannot really see where it goes. This is what we call unsatisfactory colposcopic image. Unsatisfactory means me, as a colposcopist, I'm not satisfied of what I'm seeing. I cannot really comment that this woman is having what? I cannot see the edge of the abnormality. This is what we call unsatisfactory colposcopic image. And if you go through the algorithm, you are going to find out that whenever we have inadequate or unsatisfactory changes, that means that I need to follow up this patient for a longer period, more than someone who is having adequate colposcopy. I can see where the changes start, where the end, and you can see impression of a specific CIN or no impression of CIN. I'm just trying, guys, to highlight the terms that are used in colposcopy so that you can imagine why the management lines are going to be held. So another thing that we are going to talk about, which is very important, is what's called ASCUS. I'm not really sure where it is here, but I think it's here. Yes, okay. As you can see, one of the algorithm here. I don't care really what's going on, but as you can see here, if I'm having cytology with ASCUS, what does this mean? What ASCUS mean? Actually, ASCUS is a cytology result, which means that this woman is having an abnormality, but it's not severe enough to be leveled as CIN. It's not normal enough so that I can say this is normal or physiological changes. So it's a gray area. In case we have ASCUS, the next appropriate step is colposcopy. And by far, guys, this is the most common cytology results that you are going to see in your life. Many women with positive HPV, when they are going to have their cytology, the cytology of the pap smear is going to reveal ASCUS. Whenever we see ASCUS, we are not reassured yet, so I'm going to refer her to colposcopy. Colposcopy is going to tell me if this woman really is having a problem or no. It's only changes because of any other causes. For example, hormonal changes or yeast infection, or sometimes it's because of irritation, chronic irritation. So there are so many reasons that can lead to this abnormal changes in the cytology of the transformational zone, but it's not CIN. What is going to make me sure of that? The colposcopy. Exam question. If I held the colposcopy of ASCUS cytology result, okay, so the colposcopy revealed CIN 1 or 2 or 3, what should I do? You are going to deal with the case as CIN 1 or 2 or 3. Simply. If you are seeing CIN 1 or 2, you are going to offer treatment or conservative management in specific cases. If no visible abnormality, so no, I cannot see a CIN impression. And impression means that by my grading system, no, I don't have enough points to say that this woman is having CIN. So again, it's going to be according to what? Satisfactory or unsatisfactory. Satisfactory means I can see the borders. So this is usually happen with transformation zone 1 or 2. And unsatisfactory colposcopy is usually what happen with transformation zone type 3. In case of unsatisfactory colposcopy, I'm going to offer management. Or if the patient is refusing management, we can hold NDT. In case of satisfactory colposcopy, and I cannot see abnormality, now I'm having a problem. Actually, I'm having a problem. You would say, why? Everything is good. I would tell you, yes, on the colposcopic level, everything is good, but this woman was referred to colposcopy for a reason. The woman is having what? Is having HPV positive and abnormality in cytology. Are you going to let her go home just like this? Or what? So it's like, what? She's having a risk factor, right? So I cannot discharge her or refer her to the routine recall. By the way, the routine recall in case of someone who is having a problem is 3 years. If someone who is not having any problem, HPV negative, cytology is negative, the recall is going to be every 5 years. Okay, so here again, I'm having someone with HPV positive, cytology is abnormal, and the colposcopy is satisfactory, no visible abnormality. What should I do? Actually, this needs some discussion. If the patient is having multiple high risks for cervical cancer, I would offer her biopsy to make sure, again, of what's going on. If not, I can offer her to be followed up. So, again, as I told you, sometimes we are going to offer biopsy. Sometimes we are not going to offer the biopsy. So, sometimes in those gray areas, guys, I would ask myself why the patient in the exam, it's theoretical, okay? So I need something to help me in the scenario. If the patient was referred to you because initially she is having HPV positive and high-grade cytology, or of course, granular abnormality, which is, by the way, something really severe, okay? This patient with normal colposcopy is really fishy. Something is fishy going on. How she's having those and the colposcopy is normal. So this is why I'm going to offer biopsy. However, in another patient here, where the HPV is positive, of course, but the cytology is ASCUS or low-grade dyskaryosis, and I have got a normal colposcopy, and I cannot see CIN, or even because she is high risk, I offered her the biopsy and it revealed nothing, I'm going to recall this patient after 3 years. To be honest, one of the exams, there were another options like recall the patient or offer her another testing in 1 year. Who should be offered another testing? Testing, we mean by testing HPV and cytology in 1 year. Those who are having ASCUS. Why? Because again, those patients are having changes in their cytology and you are not yet sure if this is because of the HPV or another reason. So, whenever she is having HPV in her system, the HPV is still positive, I cannot reassure this woman and refer her to the 3 years. So, I'm going to invite her again after 1 year to repeat the testing. If HPV is still positive, the cytology is still ASCUS, again, refer to colposcopy. And if colposcopy is normal, but she is still HPV positive, again, I'm going to test her again in 1 year, and so on, and so on. So this is what we call, guys, wise management or stepwise management. You need to make sure that this woman is safe. So of course, I'm not going to refer any patient to normal routine recall when she is still having a risk factor. According to her risks, we can offer her a repeat in 1 year or 3 years, or if everything is okay, I'm going to refer her to normal recall 5 years. Okay, what about 6 months? Who is going to be offered a recall in 6 months? This is what we call test of cure. Test of cure is something that you are going to offer women who had treated CIN, whether they have LATs or conization, or they were having cauterization or cold agglutination, whatever the treatment method, they were offered that treatment. So I need to do what's called test of cure. Test of cure is, again, HPV testing first. Okay, and then if it's positive, I'm going for colposcopy. And according, again, to the colposcopy results, I'm going to make my mind if this patient is cured or she still need more and more follow-up. If the HPV is negative, recall her after 3 years. Why not the routine recall? Because this woman has been treated. This woman is not totally normal. She still have risk of recurrence. If the HPV is positive, okay, and the colposcopy revealed that there is abnormalities or something, what should I do? Usually biopsy. Usually we are going to take another biopsy. If the colposcopy is normal, the cytology, nothing abnormal detected, what should I do? What should I do? HPV testing in 12 months. 12? Why 12? Because it was positive from the beginning. It's not negative. It's positive. And whenever the HPV is positive, guys, you need to have a look on this woman earlier. So I need your homework is going to be in what situations I'm going to recall this woman after 1 year, in what situation I'm going to recall her in 3 years, 5 years, 6 months, and there are very specific cases where we recall them in 3 months. This is usually when you don't have satisfactory HPV results, when you are not able to have HPV testing, or the results are vague because of technicalities or whatever. So we need to invite her again after 3 months. Why? Because this is the period where the cervix is going to regenerate the cells. So I'm waiting for new cells to appear so that I can test the HPV in them. Okay, I'm not going any further than this. Let's establish those points in our minds, okay? Before going through those algorithms, I really need you to go through the standards first, okay? And comprehend them, and then you can go for the algorithm. Shall we have an example before we end this discussion? For example, they are telling you here how you are going to deal with someone referred to you with low-grade CIN and her colposcopy is normal. If there is no evidence of CIN, either visually or on biopsy, if performed, then the woman is going to be invited in 3 years. Very common exam question. You would tell me, why not 1 year? Why not? Why not 1 year? This woman didn't need a treatment. When we refer a woman to 1 year screening, after 1 year, I mean, or recall in 1 year, Those are women who were offered treatment and still they are having a problem. While this woman here, she's just having HPV positive, low-grade cytology, normal colposcopy. I'm going to invite her in 3 years. Okay? So really, you need to make your own flashcards. Okay, I'm going to spoil you, of course, and send you my flashcard eventually, but I need you to make it first. And of course, like usual, thank you so much if you are continuing this video up to this moment. And I'm really wishing from the deep of my heart all the best for all of you guys. See you soon.